Terrier. It's their mascot. She's been at the center since 2005, and the center really does some very important work around strategies to help, especially around finances for children with special health care needs. And I would really invite anyone to go to the Catalyst Center's website, because they have this amazing 2-minute video that explains exactly what it is that they do. So Meg Comeau, who's standing here next to me now, and I'll start handing this over, has a master's in health administration from Simmons College, right? Go Sharks. I was about to say that because I looked it up. And I think that, she too not only is an expert in the how to take, these kind of policy issues around children with special health care needs, but has a unique and special understanding of it because, I can share with everyone, she has a daughter with poverty release syndrome. So I think that brings a very interesting and personal touch to this. So I think we're very fortunate to be able to have you speak to us this afternoon.
Thanks, Alex, very much. Tough act to follow. We had engineering and science and bioethics and bridges and disasters and all kinds of good stuff. Let's see. Technical assistance. Thank you. No, it's great. If that's okay for the folks in the audience. So thanks very much for inviting me to spend some time with you today. I really appreciate it. I'm going to try to go through my material relatively quickly to try to keep everyone on track with regard to the agenda. But also, this is sort of cast a wide net and try to fit in everything I possibly can into 45 minutes. So I'm going to touch briefly on a lot of things. But I do want to just give you a quick heads up that through the National Coordinating Center, we're currently putting together a series of webinars that we're going to do, Jill, on individual topics. So I'm gonna scooch over some things that I know everybody is really interested in, but there'll be opportunities for us to delve more deeply into them in the future, like accountable care organizations. That said, I also just want to sort of frame this up a little bit by saying that I think right now, this is my own personal opinion, I think right now we are in the midst of building our own bridge. We're building a bridge between where the healthcare system of coverage and financing is now and where we want it to be with the Affordable Care Act. And I don't think we know yet if we've got the Brooklyn Bridge or if we've got the Tacoma Narrows Bridge. I don't know if we're going to be able to march elephants across it. I hope so. But my own personal feeling is, during this time of building and transition and challenge, the more brains we can wrap around this, the better. So I'm very pleased to have the opportunity to talk with you all today. So Reader's Digest condensed version of who the Catalyst Center is. Alex did a great job of introducing us, and I appreciate his generosity in that. I'm very happy to share with you today that we have been refunded for another 5 years. Yay. So you're going to be stuck looking at me for a while longer, I think. We work out of the Boston University School of Public Health, but many of our team members are remote. And I also just want to say that I have the privilege of being the public face of the Catalyst Center. It's my name that's attached to a lot of these public presentations. So when people think of the Catalyst Center, oftentimes they think of me, but they shouldn't necessarily. I'm just the public face of an incredible multidisciplinary team. So let's talk for a second about why we should care about the Affordable Care Act in the context of public health and in the context of financing genetic services. So there you have two different, but not necessarily competing foci. Public health is about improving population health, and insurance coverage is about reducing individual financial risk in the face of health problems. They really are complementary to one another, though. They're not competing. They're different, but they're not competing. They're really complementary to one another. And one example of how they complement one another is, we've seen in the past that as state and federal funding has become more and more inadequate to support the 6 core components of newborn screening programs, there's been an increased reliance in almost every state on fee-for-service billing. So the private insurance coverage has tried to fill in some of those financing gaps that we have experienced in the area of newborn screening. We think it's going to continue to be incredibly important as we're building this bridge to keep in mind that there are all kinds of nuances in the healthcare system that are reliant on one another, that there are multiple variables that all have an influence on this, and really the infrastructure of public health depends on many of them. So I don't really think that we can separate the two. Insurance coverage, both public and private, isn't just a financing mechanism for keeping the trains running. It isn't just a mechanism for reimbursement for clinical services. Getting individuals on and keeping them on affordable coverage helps increase broader long-term access to care, which in turn helps increase opportunities to improve individual health, which in turn helps increase opportunities to improve population health. And I didn't make that up, the Secretary's Advisory Committee said that. I'm just repeating their wisdom. A real step in the right direction is the Affordable Care Act. There are two major pieces of federal legislation that together form the ACA. There are three areas of major focus in the ACA. The first is on insurance reforms, and that's the consumer protections or the patient's Bill of Rights, new and expanded pathways to coverage combined with an individual mandate that you have coverage, and then cost and quality provisions. I want to spend just a little time talking with you about the insurance reforms for just a second, because they're incredibly important to the patients and families that we all serve. So the major focus of getting people onto coverage and reducing uninsurance is really what the ACA is built around. There was much less focus in the law around reducing underinsurance, which is the problem that most children with genetic disorders and children with special healthcare needs in general face. It's an historic opportunity in many respects, but it isn't going to do everything for everyone. So I think one of the points that I want to try to share with you today for you to carry away is, while the ACA is incredibly important, and while the work that we do here today together and thinking about it is incredibly important, it's not going to solve the world's problems. It's all of the different pieces of the safety net that are currently out there and available are going to continue to be important. So we're going to focus on ACA, but we're going to focus on it in the broader context of other opportunities for healthcare coverage and financing improvement. Oops. So here are some big sort of hits that are important to kids and families. The first is the prohibition against pre-existing condition exclusions. That's been in practice now since 2010 for children. It will come into practice for adults starting in 2014. It basically says that a private insurance company can't deny coverage to a person because they have a pre-existing condition. Dependent coverage for youth up to age 26 on their parents' plan. That's really important for those kids in that transition age group who are aging out of child eligibility for especially Medicaid. Being able to get on a parent's plan is incredibly important. Those kids who either didn't have access to Medicaid before or who can't get on Medicaid as adults, this is going to be an important opportunity for them to continue to get coverage. No rescission of coverage. Insurance companies can't throw people off of coverage because they get sick. Guaranteed issue and guaranteed renewal will come into play in 2014. That means that if you are eligible for private insurance, they have to offer you a policy and take you into the plan. And if you are in already, they have to keep you if you remain eligible. The Section 2705 prohibition against discrimination, I think, is incredibly important for our population because it's based on health status, but it explicitly lists genetic information as one of the health status factors that cannot be used for denying a person private insurance coverage. And that's going to go into effect in 2014. This is complementary to what's already in effect with regard to GINA, the Genetics Information Non-Discrimination Act. There's nothing in either of the two laws, ACA or GINA, that are in conflict with one another. They're actually both very complementary to one another, and the ACA just reinforces that. Annual and lifetime benefit limits. So effective now, there are no more lifetime benefit limits for anyone in a health insurance plan, a private health insurance plan. There are no annual benefit caps allowed of less than $2 million. And then starting in 2014, there will be no annual or lifetime benefit caps allowed. So that's great. There is a caveat associated with that, though, that I think we need to be aware of. We're talking about dollar amounts when we're talking about no annual or lifetime caps. We're not talking about benefits themselves. So the number of visits or the number of services or the number of sessions can still be limited. You just can't put a dollar amount on them. PT, OT, speech, habilitative therapies, that's an issue I think we're going to keep an eye on. With regard to new and expanded pathways to coverage, One of the first that is getting a lot of attention, and understandably so, are the state exchanges, the marketplaces. They'll open in 2014 in every state. They'll open for coverage in 2014, but they're going to open for enrollment in October, which is right around the corner. So states are scrambling right now to try to figure out, what's going to happen with their exchanges and how they're going to operationalize the whole thing. It's a very, very complex project. It's complex in terms of information technology. It's complex in terms of integrating what the ACA calls for with existing state law and federal policy. It's a big deal, and it's a real challenge for many folks. So that's all going on right now. There will be a choice of different individual policies and small group plans within the exchanges. It's important to remember that folks who are going to be eligible for exchange coverage are those who buy their insurance either in the individual market or the small group market. And small group is defined as under 100 employees. Most kids with special health care needs get their insurance through large group employers. But this is still an important avenue for coverage for people who are currently uninsured or who have trouble affording their insurance. There'll be help for consumers in choosing a plan, comparison website, navigators, assisters, people who can sit down with you, help you fill out the form, help you figure out what coverage options are available to you. One of the big IT questions that states are going through right now is the ACA calls for, I guess the best and easiest, well not the best way, but the easiest way to think about it is the ACA calls for a sorting hat. So when you put in your application for coverage, it's supposed to sort you. There's supposed to be some kind of an algorithm available that sorts you into either Medicaid or the exchange or the children's health insurance plan. That's a complicated thing for many states because right now their systems don't talk to each other. And the exchange system is a totally new one that's getting layered on top of existing CHIP and Medicaid. So this isn't one example of the things that states are struggling with. Oh, almost forgot a really important part, tax credits and subsidies between 100% of the federal poverty level and 400% of the federal poverty level. So that is a companion piece to the requirement that everybody have insurance. Here's some help with tax credits and subsidies for folks to be able to afford it. This is a little chart that tells you where states right now in this region are with regard to their health insurance exchanges, what kind of insurance exchange they've decided to run. And I have to apologize to the folks from Puerto Rico and the Virgin Islands. I couldn't find any what I considered really authoritative, accurate information on their choice. There may not be an exchange in those two states. I'm not 100% sure, so I apologize for that. But you can see there's a pretty standardized run here. Everybody has deferred to a federally run exchange. No state has decided that they're going to run their own. Within the exchanges are a requirement that the plans offer essential health benefits. The essential health benefits are, I think, the place where a lot of people put a lot of emphasis and interest when the ACA first came out for addressing underinsurance. But as it's sort of shaken out, I think we have less and less confidence about that. But it's still going to be really important for those kids who get their insurance through the exchanges. Whether or not it's really going to solve every problem for everybody is a question, but it still holds some promise. I certainly don't want to dismiss it. The ACA requires that individual and small group plans, those sold within the exchange and outside, include the essential health benefits. One thing that you need to be aware of is that plans that cover large groups, over 100 employees, are exempt from the EHBs, as are grandfathered plans and self-funded plans. And right now, about 60% of folks who get private insurance get them through a self-funded plan. So it's another sort of caveat to be aware of. The requirements under ACA with regard to the essential health benefits are that they have to reflect those benefits that are covered by a typical employer plan, and that was typical in 2010 when the law was written, you'll recall. The EHB definition can't make coverage decisions, determine reimbursement rates, establish incentive programs, or design benefits in ways that discriminate against individuals because of their age, disability, or expected length of life. So this is another anti-discrimination provision within the ACA that I think has relevance to our population. The EHBs have to take into account the health needs of diverse populations, and by the way, pediatric populations were one of the specific groups that was called out in the ACA. It has to include benefits under 10 broad service categories, and the benefits have to be balanced among those 10 categories. And here are the 10 categories. Now, you all might remember when the ACA passed and we all saw this list of 10 benefit categories, I had a real problem looking to think of any kind of service or benefit that couldn't conceivably be fit in one of these categories. So I thought, woohoo, this is the answer to our prayers. This is the answer to our problems. We're going to get ABA under habilitative services. We're going to get medical foods and formulas under one of these categories. We'll figure it out. It'll be great. The original plan was that there was going to be a standardized national standard for the EHBs in all of the states. As the ACA was passed, the Secretary of Health and Human Services was directed to determine the exact duration and definition and scope of all of these different benefit categories. So there was a very complex and very thoughtful process that went on, thinking about getting reports from the IOM, from an expert work group on how to think about this issue, how to think about coming up with a plan, talking to other experts, talking to the folks at ASPE, talking to the folks at the Department of Labor, talking to the folks at Treasury, talking to the folks at the other federal agencies who have stake in the game when it comes to ACA, and nationwide listening sessions, listening to advocates and getting comments from folks, getting comments from clinicians, getting comments from insurers, getting comments from all the different stakeholder groups, and how to try to figure out a fair and equitable way to determine this national standard. The decision was made that it wasn't going to be possible to figure out a fair and equitable national standard. So instead, the decision was made to go with states choosing a benchmark plan based, again, referencing what the ACA says about it, the essential health benefits looking like a typical benefit package in process, in operation in 2010. HHS authorized states to choose from one of the these four different kinds of benchmark plans. So you can see one of the concerns that we have as we're moving forward here and analyzing and thinking about how this is shaking out is if we're building the new system of essential health benefits on the old system where we know there are gaps in coverage, especially for kids with special health care needs and genetic conditions, then are those things just going to get replicated in the new essential health benefits? So I think we're all trying to keep an eye on that. States went through a process of thinking through which of these four different kinds of benefit, one of these four different benchmarks that they wanted to choose. Just over half the states decided they weren't going to make this decision. They were going to defer to the federal government and let them run their exchange. And by default, they went with one of the largest small group plans in the state. So the other the other half of the states decided that they would either run their own exchange, and they chose from this menu of four, or that they were going to run a state and federal partnership, and the state decided that they would choose their own. I want to give you a couple of resources here where you can find out more information for your particular state. The Center for Consumer Information and Insurance Oversight is run by CMS, and they have gathered all of the information on the state benchmark plans. And they've also gathered all of the information on the state mandated benefits and put them together in this handy-dandy webpage for us. If you open this website, and you can see the link up at the top of the slide so that you can go directly to it yourself. If you open this up, this is what you'll see. And then if you scroll down, you'll see a list of not only all the states, but I was thrilled to see the territories as well, because I felt really bad about Puerto Rico and Virgin Islands not being able to find out more about them. But they are listed here, along with the other territories. So you can see Alabama is listed first, not surprisingly, alphabetically. If you click on the guide for reviewing EHB benchmark materials, which I strongly recommend you do if you're gonna take a look at this, because it'll help you understand what information is being presented to you. Click on that first, sort of read the little two-page guide on how to think about what you're about to see. Then if you click on the summary of EHB benefits, limits, and prescription drug coverage, you'll see this. You'll see a little summary sheet. This was Maryland. It happened to be the one I clicked on first. Maryland, it'll show you what kind of plan type they chose, the state chose, who's issuing it, what the product name is, how the categories for pediatric vision and oral health services were supplemented, whether or not habilitative services were already in the benchmark plan and whether they need to be supplemented, and how they're going to be defined by the state if they weren't there already. And then, if you go over to the column on the far left here and click on benefits and limits, it'll tell you exactly what's in that benchmark plan. The benefit itself, any limits associated with it, who it applies to, what kind of group it applies to, what kind of sort of clinical group it applies to, give you all the information you need about whether or not a specific service is covered in your state's benchmark plan. One last thing that I think is a really helpful part of this CMS website is information on the state mandated benefits, because they're integrated into the essential health benefits as well as still remaining in effect and in force for people in private insurance. The ACA said that states had to cover the cost of state mandated benefits, laws that require that benefits be covered in private insurance that were already in place before the ACA was passed. A lot of states with a robust group of state mandated benefits had a little panic attack for themselves because they thought, well, here we've been trying to do the right thing. We've been trying to help out the folks with rare and low incidence and expensive disorders by passing these mandated benefit laws so that they can get what they need. And oh crumbs, now we're going to be on the hook for the cost of that. The rule came out, there was a response to that concern, that it wasn't really fair for states that had been, sort of trying to do the right thing to get penalized for that. So the rule came out that any state mandated benefit that was in place before December 31st, 2011 will automatically be considered part of the essential health benefits. And so there'll be no additional cost to states for them. Moving forward, whether this is going to have a dampening effect on new state mandated benefits, I'm not sure, but I wouldn't be surprised if we can't make a strong case for a specific mandated benefit being included in one of those 10 benefit categories or having some kind of connection to the state's benchmark plan already. Only state mandated benefits that impact care, treatment, and services apply. Any limits in the law, in the original law, still apply. Going into the future, exchanges are going to be responsible for identifying the state mandated benefits, new state mandated benefits that go above and beyond the essential health benefits, and insurers are going to be responsible for identifying the cost. See about that. This is the list of Maryland's state required benefits. So if you're interested in knowing, does my state have a mandated benefit for medical foods and formulas? You can go to this website. You can click on the state required benefits, which are the state mandated benefits, different terms, same thing, and actually find out. You can also find the citation number. You can Google search this and go right to the law itself and read it for yourself, or you can give me a call and we can read it together. So let's talk for a second about the Medicaid expansion. The Supreme Court last summer heard a case challenging the constitutionality of the ACA. And I think many people were on tender hooks about what that was going to mean. Many people were excited about what that was going to mean. Depending on where you sit, you were either thrilled or disappointed with the decision that came out. Basically, what the Supreme Court said was that one of the provisions within the ACA that was the basis for the constitutionality challenge was the individual mandate. Can you really force people to buy something? What the Supreme Court said was that the individual mandate is a tax, and Congress has the power to levy taxes, so the law is constitutional. It's upheld. The provisions that have gone into effect will stay in effect, and the ones that are scheduled to roll out will continue apace. There was, though, one exception to this, and that's the Medicaid expansion. So, as originally written, the Medicaid expansion provision would have required all states to allow non-disabled, non-pregnant adults ages 19 to 64 to enroll in Medicaid. And this is a new population. Right now, states don't generally cover folks, regardless of their income, if they're not disabled, not pregnant, and they're adults. It also raised the income level, the minimum income level, to 138% of federal poverty level for all populations, both new and existing. The Supreme Court said that the penalty in the law for states not complying with the with the Medicaid expansion was too coercive. The penalty was if a state didn't expand its Medicaid program to this new population of adults, then it would lose all of its federal funding for its entire Medicaid program. If you think about carrots and sticks, that's a pretty darn big stick. And the Supreme Court said basically that's too much. It's coercive. A state really doesn't have a choice. So this expansion is still allowed under the law, but it's a choice that states can make. It's not a requirement. Here's where we stand with the most recent information I was able to gather on the states in the region about whether or not they're planning to expand their Medicaid program. Does this come as a surprise to anybody? 2 quick thoughts. It came as a surprise to me when we heard about Florida, because that was a big deal. I have another slide like this for a different region, which includes Texas, and it doesn't just say no, it says no with an exclamation point, and it's in bold. And if I could fit in the little category, no, seriously, we're not kidding, don't ask us again, I would. But Florida is a yes now, which is very exciting. The governor said yes. So, but this, absolutely, those 2 things have to be in alignment with one another. It's not a done deal, but still, that's better than no with a capital exclamation point, don't ask us again. In Tennessee, I understand there's some debate between the governor and the legislature, and they've come up with an alternative proposal for doing something with their Medicaid program, which if they decide that they're going to move forward with it, is probably going to require a waiver, not a straightforward ACA Medicaid expansion. So I have to see how that works. It's my understanding in Puerto Rico that there is no plan to expand Medicaid, and I think that there's still some debate going on in the Virgin Islands. So uncertain about what's going to happen there. Now, there's an important caveat for us all to be aware of. When we talk about Medicaid expansion being optional, that's for that new population of non-disabled, non-pregnant adults. Children were an existing Medicaid eligible population. And so states are required to expand their Medicaid eligibility to 138% of the federal poverty level for them. There'll be no change in states with higher income eligibility levels. So some people have asked us, we know the floor is going up to 138%. Does that mean the ceiling's coming down too? No. If your state already covers kids above 138%, that's not going to change. And it can't change by law until at least 2019. Kids in separate CHIP programs are going to move, whose family income is below 138% of FLP, they're going to move from the separate CHIP program, where the benefits and the cost sharing look a lot more like private insurance, to Medicaid. So that's a good thing for kids and families. These are the income eligibility limits for kids for regular Medicaid and CHIP-funded Medicaid expansions in the states in our area. Unfortunately, I don't have time to go through them individually today, but there's the information, and we can always talk about it offline if you'd like. This is the income eligibility for separate CHIP programs in the states. Let's talk quickly about cost and quality provisions. There's an increase in the Medicaid primary care reimbursement rates to match the Medicare rate. It's my understanding that recent research shows that that really hasn't hit the street yet, that a lot of Medicaid primary care providers haven't seen that money yet. So there's a question about whether it's really going to be the big deal that everybody was hoping that it would be. As demand goes up, we saw this in Massachusetts when the health insurance reform came into effect about 4 years ago. As more people have insurance, more people actually want to have health care, and so there's more demand. There isn't necessarily more supply, however. So provider shortages and long waits, especially for primary care appointments, were something that we saw in Massachusetts. And so we're sort of trying to keep our eye on this a little bit. There are some provisions in the ACA to try to address that. There's an investment in the National Health Service Corps and some other workforce development and education provisions that I think could be helpful, but they're long-term investments, and so I think we're going to all have to keep our eye on that one. The ACOs, that's an hour-long talk all by itself. One way to think about ACOs, I just want to offer you 2 thoughts on the ACOs. One way to think about it is as a medical home neighborhood. So you have all the individual medical homes, and then in an ACO, you try to bring them all together and make them an integrated system, make them an integrated network, along with the specialists and all the other folks that provide care. It's sort of a big picture way to try to think about operationalizing care coordination from the standpoint of clinicians. I think a little bit of that is bridge building. maybe it's the Brooklyn Bridge, maybe it's the Tacoma Narrows Bridge. We'll have to see about that. There are some very specific pieces, though, that are incredibly important to kids that I think we all need to be aware of and we need to be lending our voices to, because the ACOs are really looking at high-cost folks, and kids just aren't them. If we look at individual diagnosis-specific populations, we can think they're high cost. But if you think about the big bucket of healthcare spending, it's a teeny tiny drop in that healthcare spending bucket. So we need to make sure that folks are thinking about the needs of pediatric patients, and especially folks with low incidence and rare disorders. We need to know that there's adequate provider networks, especially specialists. That was great. You know what I mean. That there are opportunities for risk adjustment that are pediatric specific, that there are quality guidelines that are pediatric specific. You know, let's not just be measuring whether or not this accountable care organization is operating well by looking at adult patients with chronic illnesses. Let's look at the entire group of folks who are enrolled in it. Health homes for Medicaid enrollees with specific conditions. This is another one that I think we're going to do through the NCC as a dedicated topic-specific webinar. Section 2703 of the ACA. I see that I'm running out of time. So I'm just going to skip through this quickly. I get asked a lot, what's the difference between a medical home and a health home? There isn't any. They're both the same thing. Except when you're talking about Section 2703 of the ACA, then you're talking about something very specific. You're talking about a mechanism for financing specific medical home components like care coordination for Medicaid enrollees with chronic illnesses. So everybody can use a medical home, everybody can use a health home, but this is very specifically targeted. This is another one of those state options. States can choose to do them or not, and there are about 12 states now that currently have 2703, thank you, 2703, health homes in operation. I believe Alabama was the latest one. These are the eligibility criteria. See, again, it's Medicaid enrollees. This is how chronic conditions are defined. I just want to point out this one piece at the bottom here. States can add other chronic conditions. I think when a lot of us looked at this list, we thought, relevance to pediatrics? States can add other chronic conditions that are pediatric specific to their state plan amendment for review and approval by CMS. So you're not limited to these things, which I think is an exciting opportunity. These are the services and supports that are included. There's an enhanced federal match, so it's 90% for the care coordination services that are offered and the patient education services that are offered for 2 years. So this is a way to get some additional money into the system to help fund care coordination and really try to think about, you know, now we have a way of funding it. Now we have a way of supporting it through financing. Can we now do a more robust evaluation of its effectiveness than we were able to do before when we just had, you know, sort of pilot money and a little bit of grant money here and there? The provider types are very robust as well, and they include specialists. So that's a question that we get asked a lot too. You know, this is great, but you know, medical home is primary care. You know, what if I'm a specialist and I'm in effect providing a medical home to my patients with rare and complex disorders? You are eligible for the enhanced federal match under this SPA if your state chooses to do it. I think Alex mentioned preventative services. Now, one thing that I get asked a lot is, well, it's great about preventative services, but you know, they're limited, like the essential health benefits, right? No, preventative services are really, this provision, 2713, really covers everybody in private insurance. It's not just for folks in the individual and small group markets. This is separate from the essential health benefits, but there is a connect between them. So for people covered by new employer and individual plans and policies, and pretty much everybody has a new policy now because this went into effect back in 2010, the following services have to be covered without co-pays, co-insurance, or deductibles being collected or charged. So here we have the recommendations of the United States Preventative Services Task Force. It's a nice, robust group of preventative services. The recommendations of the Advisory Committee on Immunization Practices. Bright Futures, very important for kids, obviously. HRSA's Women's Preventative Services, and the rest. The recommendations of the Secretary's Advisory Committee on Heritable Disorders in Newborns and Kids. So I think this is a way to help try to get some more money into the system if these things have to be covered. And it also is a way to get more money into the system that doesn't necessarily mean that it's being covered on the dime of kids and families. So this is coming from the insurers, which I think is helpful. So this is my quick summarization. The ACA offers historic opportunities, especially around improving access to universal and continuous and affordable coverage. So getting people onto coverage is the first step. And it really offers some good, robust opportunities for that. There's increased attention and investment in public health, in the infrastructure, and in primary care in the ACA, which I think is also incredibly helpful and important. It doesn't do everything for everybody. For example, there are exemptions to many of the provisions, like the essential health benefits being exempted from large group plans and self-funded plans. The essential health benefits are being built on existing coverage. So I think that's something that we all need to be aware of and keep an eye on as that rolls out. Is it working? Is it not working? The plan right now is for the Secretary to look in 2 years and survey the states and see how things are actually working with regard to the benchmark approach for the EHBs. So we should be collecting information and data now from kids and families about how it's working for them, how it's not working for them, so that we can report that back, have the evidence that we need in 2 years to say, this is good, keep it, this needs some help. Long-term sustainability of state and federal funding is a significant concern. So we're already seeing changes being made. The ACA, as passed in 2010, was a 2,000-page document that had a lot of content in it and a lot of good stuff, but a lot of unanswered questions. As those questions are getting answered, I think in some ways we're seeing some improvements to it. In some ways we're seeing a little bit of a death by 1,000 paper cuts. So it's something that we need to keep an eye on and try to lend our voices to as much as possible. Whenever there are rules and regulations that come out and a call for comments, we should have our voices at that table. When states are working on these individual decisions they have about whether they're going to pick up Medicaid expansion or whether they're going to pick up a 2703 SPA, we should be at that table trying to help make sure that our patient population is covered. The need for the safety net, especially that provided by public health, is still incredibly important. The ACA isn't going to do everything for everyone, so we need to continue the hard work that we've been doing to try to improve the system of coverage and financing for our kids. That's the end. And we have no time for discussion or questions, I'm sorry.
If you have questions, please come to the aisle microphones.
I'm going to take off my glasses so I can see folks.
Cecilia Belcross-Emery. And this probably is my ignorance, but how do you decide who's going to be grandfathered? I mean, what's that? I mean, so those insurance companies that are grandfathered and don't have to come under this, who decides that?
That is a really good question. So a grandfathered plan is one that was in effect when the law was passed on March 23rd, 2010. The way a plan becomes ungrandfathered, so going back just a little bit, there was a lot of debate just before the ACA was passed. There was a big study that came out that got a lot of media attention that said people in the United States like their health insurance the way it is. We don't need this healthcare reform thing. It's fine. The system works fine. Okay. That part of the study got a lot of attention. The part that didn't get as much attention was everybody who said it works fine, they're the people who are typically healthy, typically developing, who don't use it. If you ask the folks with chronic illnesses, disabilities, and special health care needs what they think of insurance, it's a mess. That didn't get as much attention. So the political compromise that was made was, if you like your health insurance the way it is, to try to generate support for the law, if you like your health insurance the way it is, it's not going to change. You're not going to lose anything by this. The ACA isn't going to take anything away from anybody. It's going to give things to people. It's not going to take anything away from those typically healthy, typically developing people who like what they've got. So that's where the concept of grandfathering came in. So a plan that was in place when the law was passed was grandfathered and exempted from many of the new provisions, so that people could sort of ease themselves in, insurers could ease themselves in, patients and families could ease themselves in to these changes. As either premiums go up or benefits go down, a plan loses its grandfathered status. So it's no longer a new plan anymore. It's a different plan. It's no longer a plan that was in existence in 2010. It's a new plan. So that's why a lot of these slides you'll see say for new plans, for new plans. A lot of plans just renew every year. Some of them stay the same, stay relatively stable for 2-3 years, but eventually, given healthcare economics, either premiums have to go up or benefits have to go down. And so eventually, grandfathering will just completely go away. It's just going to take some time for that to happen. Great question. Sorry I didn't cover that earlier.
I guess I don't understand how we're moving forward when so many states refuse to have a state-based Medicaid exchange system. So what's the default when that doesn't happen?
So there's a Medicaid expansion, and then there's the state-based exchange, and they're different things. So the Medicaid expansion is expanding income eligibility for Medicaid. Waivers and other pathways to coverage through Medicaid that are currently in law are going to stay. We're not going to lose any of our home and community-based service waiver programs. We're not going to lose any of our current existing income eligibility guidelines. They're just going to go up. But for states, in terms of the exchanges, those are for folks who need to buy their insurance either individually and they need to buy their own policy because they don't have access to employer coverage, or they're in the small group market under 100 employees. So those are kind of two different things.
Got it, yeah. So aren't there states saying, no, we're not going to do that with Medicaid?
There are states that are saying, no, we're not going to do the Medicaid expansion, and that is their right because the Supreme Court ruled that the feds couldn't say you have to do it. States don't have a choice about whether or not there's going to be an exchange. What they have a choice about is whether they're going to run their exchange or whether the feds are going to run their exchange. Does that make sense? Okay.
Hi, are there any of the essential or state-mandated benefits that address infertility services? Like in vitro fertilization, or do you know about that?
Yeah, if it's in the benchmark plan already, then it would be included. Or if there's a state mandated benefit for it already, then it would be included. In terms of whether something is covered without a copay or deductible, I don't think that falls under the category of preventative services. So I don't think I don't think the women's health guidelines, I'm sorry, I haven't read them carefully recently, but I don't think the women's health guidelines have anything about infertility. But in the exchange plans, under the essential health benefits, if it's in the benchmark plan that the state chose, and you can go to that site to see for your particular state, or if it's already in statute as a state mandated benefit, that's not going to go away. That'll continue. I guess the question will be whether or not the state being on the hook for additional benefits that go above and beyond the essential health benefits, whether that'll be interpreted, and that might have a dampening effect on state legislators wanting to pass new state mandated benefit laws if they're going to be on the hook for the cost for it. Sure.
First of all, thank you very much for a very nice talk on an incredibly complicated topic. Every time I think I understand what's going on, I hear this kind of thing and get more confused.
I come in and confuse you more. Oh no.
But I mean, there's still obviously a lot of stuff to think about. What I'd like to do though is drill down and ask you a couple of questions about the coverage for preventive services, because I think that's something that this group thinks a lot about. So the first thing is, as you mentioned, things that the Secretary has endorsed onto the recommended uniform screening panel. Are covered. So if you live in a state that doesn't yet screen for severe combined immunodeficiency disease, which a fair number of the states do, then you as a parent could actually somehow demand that it gets done, and somebody would have to pay for it somewhere,
Yeah.
regardless of how it would get done. Is that correct?
That's our interpretation, yeah.
And then the second thing is, for preventive care, at what point does that coverage end? So at what point does the law consider the preventive care treatment? Does it just cover the actual screening test, or does it cover diagnosis, or, because when I looked at the Affordable Care Act, it just says it covers these preventive services, but the preventive services, if you think about them broadly, are the whole thing.
Right. It's interesting that you asked this question, because I just had a long conversation with somebody from Oregon yesterday about in the law it says that behavioral assessments are part of preventative services and have to be paid for. So does that mean an hour-long behavioral assessment by a specialist is going to get paid for? We really thought about it a lot. We talked to the folks at CMS. We talked to some other folks at HHS and figured out that it's really based more in screening than treatment. So we went back and we took a look at Bright Futures. So Bright Futures calls for developmental assessment, but it's screening. It's looking at the kid and trying to figure out what's going on within the context of a primary care office visit. It's not a visit to a specialist. It's not follow-up. It's not treatment, which is probably not the answer we want, but. Absolutely. Now, I can answer that question more authoritatively when it comes to early periodic diagnosis, screening, and treatment for EPSDT for Medicaid. We know that. I think we're still trying to figure out where that line is. in terms of the essential health benefits and their intersection with preventative services provisions. If you have a specific question about that, I would reference back to the list of benchmarks in the preventative services. So go to Bright Futures and look and see exactly what it says, because I really think that that's where they're basing the decision around that.